We will start this session. This is Game Changers in Corneal Procedure. Over the years, the corneal surgeries have evolved and it has reached a stage that newer and newer innovations are coming up, which are changing the way we are dealing with the corneal patients, treating them, and it is also giving them wonderful results than it was many years before. So for the last 1 decade, we have got few surgeries that has become the game changers, and few of them are being highlighted here. We'll start this with the SLED procedure, simple limbal epithelial transplant, the new horizon. The speaker is Dr. Mallikarjun, is head of department, Shankara Eye Hospital, Cornea and Cataract Refractive Surgery.
Thank you, Dr. Sujit, and thanks to Dr. Srini for giving me this opportunity. Earlier, the SLED procedure was described by Dr. Sangwan in 2012, our own Indian surgeon. But earlier, it is understood that it will modify the stromal structure also. But now, what evidence says that it only regenerates the corneal epithelium. So it doesn't act on the stroma. So it is very important to know the limbal anatomy of the eye, because there is where the limbal stem cell will be there. And these limbal stems are unipotent. That means they produce only one type of cell, that is corneal epithelium. So these cells, they start migrating toward the center and form the epithelium, and it will be regenerating continuously. So that these limbal stems are taken and transplanted to the eye which has no limbal cells. That is the main principle of SLED. And advantages of SLED or other procedures are it is a single stage procedure and doesn't need any multiple procedures, and is easily affordable, and more importantly, it doesn't require any sophisticated lab, and anybody can do it. The indications, most common indication is unilateral limbal stem deficiency because of chemical injury and thermal injury, that is more common in India. And nowadays we are doing it for large, after large excision of OSSN and large pterygium surgery, recurrent pterygium surgery, and also in a severe VKC, which is also one of the cause for limbal stem deficiency. And the same conditions, if they are present in a bilateral, so we have to go for allogenic SLED. In autologous SLED, we take the graft from the other eye. In allogenic SLED, we take a graft from a living relative or cadaveric eye. So preoperative consideration, we take limbal tissue from the superior limbus, because there is where the more number of limbal stem cells will be present. And if you are taking for a cadaveric eye, it should be very fresh and less than 2 hours from the harvesting. And there should be a good intact limbal pellicytes. A pellicyte shows the presence of limbal cells. And in a recipient eye, it should not be a very dry eye, which is a contraindication for SLED, because the result will not be that good. And if there is very severe stromal ossification, that patient may later require the DALC or PKP for the visual correction. And preoperative ASOCT is a very good tool, because we won't see anything below the vascularized cornea. So if there is a thin cornea, and if there is a fully opacified cornea, if there is a perforation, all those things can be seen in ASOCT, and this will help us to do our surgery. Poor prognostic factor like eyelid, if there are antropion, ectropion, lag of thermals, poor blink rate, and conjunctiva, they have symblepharon, severe keratinization, and these will be a poor prognostic factor. These things should be corrected during before the surgery, or if possible, it should be corrected during the surgery in the form of mucous membrane graft and other procedures. And if there is a very full thickness corneal ossification, the result will be poor. This is the procedure how we do. This is the chemical injury, and first you have to do a peritomy, first 360 degree, and actually you have to go into the plane of the vascularized area. So you have to dissect between the cornea and the vascularized panels, and you should not be very more enthusiastic to go deeper. And minimal cautery you have to do, and first what I do, I put the amniotic membrane with the glue, and you should be very careful that glue should not go to other areas of the ocular surface. Sometimes what happens, if it goes in the fornix or if it touches the eyelids, there might be contact and adhesions later. And I do this sequential method of doing. First, I put one component of the fibrin glue, and later I put the another component of the glue. That would give us more control over the application of this glue. And this amniotic membrane should be tucked in below the conjunctival dissection. That is very important because it might, the conjunctiva might migrate there below the. This is how we harvest the limbal tissue from the other eye. This is a unilateral stem cell deficiency, so I am taking a tissue from the other eye. So you need to go little bit, dissect into the cornea and also the conjunctiva, limbal conjunctiva, and take a very small bit of conjunctiva. It can be just 3 by 4 millimeter, and cut them into a small, very small places. And these are placed on the amniotic member, which is on the cornea, and the tissues are not put on the pupillary area and also near the limbus. And later you put a bandage contact lens, and that is the completion of the surgery. Post-operatively, if you are doing autologous SLET, it needs a treatment combination of steroids and antibiotic, and it is tapered out usually for 6 months. 6 weeks, and BCL is removed once the epithelium is healed. On every visit, you have to do a fluorescence staining and see if there is a epithelial defect. You have to continue BCL till the epithelium heals. In allogenic graft, there is a very minimal risk of rejection. So that's why this immunosuppression and all should be continued little bit longer time, and also you should follow up the patient. So signs of rejection are, it will be sudden drop in the vision or epithelial haze. These are the signs of rejection. When there is such signs are there, you have to increase the immunosuppression. The how SLETs works actually. Amniotic membrane helps to in proliferation and migration of the epithelial cells that is placed on the cornea, and these tiny bits of epithelial cells, they start multiplying the cells. In each area, they start multiplying cells, and they form a small epithelial cells. And all this together, they coalesce and form a sheet of epithelium. That's how it works, SLET. The complications are very less in SLET procedures, and they do happen, and there might be a local LSCD at the donor site, is very rare, and the hemorrhages under amniotic membrane is common, but no need to do anything for that because it will absorb by itself. And there can be recurrent symplepharon, a sterile microbial keratitis, or persistent epithelial defect. And one more important complication that can happen, migration of conjunctival epithelium below the amniotic membrane, if the amniotic membrane is not stuck properly over the surface. This is the high definition ASOCT of SLET patient who has undergone SLET. This is on the first day. You can see the epithelial tissue here and BCL and amniotic membrane here. And on the 5th day, this epithelial tissue is just expanding. That means it is the cells are producing. And on the 8th day, you can see 2 epithelial transfer there. They are again growing over here and covering. On 10th day, again this area becomes larger, so it indicates that there is a epithelial growing here. At the end of 6 months, you can see these epithelial tissue, transplant tissue are not seen, and the cornea epithelium looks nice, and it is covered all of the cornea. There have been many modifications of this SLET procedure, and especially in the recurrent pterygium. Actually the pterygium is also one of the cause, it is due to the limbal cell deficiency. After excising the pterygium, you place the amniotic membrane on the scleral side and on the cornea side. On the cornea side, you put a small bit of epithelial cells that would prevent the recurrence, and also it will replenish the stem cells. And this is the standard SLET procedure where you put the amniotic membrane and over that we put a epithelial cells. And there is a modification where you put a epithelial cell first, over that put a amniotic membrane. This has been published and done in one Chinese group. What they say, this epithelial cells will not dislodge, and also it will help in the modification of the stromal opacification. I don't know exactly. I don't know. I don't have. That is their claim actually. And one more complication of this SLET is the connectal epithelium can migrate below the amniotic membrane and come over the cornea. So to avoid this complication, the standard technique has been described. And what is done here is amniotic membrane is placed and epithelial cells are placed. Over that, one more layer of epithelial amniotic membrane is placed, so that these epithelial islands are sandwiched between, so that they will grow in that area only, and also it will avoid the migration of the congenital cells. In conclusion, cells is a very good option for LSCD, and it is very easy to perform, and anybody can do this procedure. If you see a video and if you just see any article, one can do this procedure. Thank you.
Thank you, sir, for a very concise presentation on SLET. We'll take few questions for sir because he has to go for another presentation. Any question from the audience? So for the allogenic, do you give oral immunosuppressants also?
For allogenic?
Yeah.
No, I am not giving any oral. I start with topical only, and frequently I follow up the patients usually. And if there is a chances, if you see any signs of recurrence and all, then I'll go pulse therapy, immediate pulse steroids. And usually I don't give oral immunosuppression. And
any experience for you and using SLET in acute chemical injury or
rejection?
Acute chemical injury.
Acute chemical injury, I actually I have not tried, but earlier I used to do total limbal around 4 o'clock, 5 o'clock congenital transplantation. That has helped me. But I am not doing that in acute stage because it will be a lot of inflammation and all, the failure is more.
Dr. Vinay, any points to add?
Nothing much. The only other thing I want to ask you is, in allografts and alloslets, do you prepare the patient with the pre-op IVMP, IV steroids before doing, and in the initial post-op period, do you continue IV steroids?
Yes, I make sure that first inflammation is controlled, one thing, and also pre-operatively just I start 15 days, topical, that's all.
That's it.
Not oral.
In the perioperative period, no systemic steroids at all?
No, I'm not giving.
Okay. Thank you.
Sir, in patients with OSSN and pterygium, when we do it, their main complaint is they're not able to see because of the amniotic membrane. So anything to be done for the central visual axis where we cover the amniotic membranes?
No, there are some surgeons, they are doing in the pupillary area, they are not putting the amniotic membrane and all. But what happens, this amniotic membrane over the period of time, it disintegrates.
So
Okay.
patient counseling.
So it is better to have amniotic membrane than not to have it. Because trying to cut in the center, then there is a possibility of this amniotic membrane may dislodge later. And it is very difficult, very thin and fragile structure. It is very practically it is very difficult to cut at the center at a hole, making a hole and all.
Yes. Thank you, sir. You have anything? Shabas, no. Okay.
If there are no other questions, thank you, sir.
Thank you.
Thank you. We'll have the next speaker, Dr. Madhu. He'll be speaking on Bowman's membrane transplant, bridging the gap in the management of keratoconus.
Very good evening to all of you. Thank you, sir, for making me part of this IC. Thank you, Srini, sir, for inviting me to this KSOS Golden Jubilee celebrations. So in the next few minutes, I'll share our experience with this Bowman's layer transplantation in the treatment of advanced keratoconus. So why Bowman's layer? So if you see the John Marshall's lecture, so he tells that you can consider Bowman layer as the tendon of the eye because they provide a good mechanical, biomechanical strength. So this is not something new. This has already been done by the Mellis group and they have already several publications. So how is exactly our technique different from theirs? Because if you see, this is what we are doing is not an isolated Bowman's layer transplant. We also try to harvest 70 to 100 microns of stroma along with the Bowman's layer. So this helps us increase the central corneal thickness, attaining more flattening, and this procedure has a relatively less learning curve, and to be precise, it should be called as the Bowman's layer stromal transplant. So if you see, the Mellis group themselves have stopped doing the isolated Bowman's layer. In the last World Cornea Congress, now they are putting 2 Bowman's layers as an overlay. So in India, myself and I think Dr. Vikas sir are doing this procedure, and both of us are using the stroma along with the Bowman's layer. So this is the video of the procedure. So I don't have access to a femtosecond machine, so all this thing is done manually only. So first I'll show you the donor preparation. After mounting the donor tissue onto the Barron's anterior chamber like you do a DSEC, you debride the epithelium and stain the Bowman's layer with help of blue, and it's usually restricted to the central 7.58 millimeters. Like you do a can opener, you just create a groove with a bent 26 gauge needle all around. And once you have a groove, then you have access to create a layer with help of your crescent blade. So once you get into that, then you can just expand that thing 360 degrees. And while you are expanding, it's important that your left hand creates a traction so that the plane in which the dissection happens is kept in a smoother plane and you don't have any interface issues later. So almost after completing 3/4 of this, you can just peel off the remaining thing. So that's the Bowman's layer with 70 to 100 microns of stroma. You can also use a guarded blade to determine the depth. So once this is done, again you refine it to the desired any size between 7 to 8. We usually take the 7.5. Initially we are using this 7 millimeters, but now routinely we use the 7.5 mm refine. And you can also nicely smoothen out the interface surface either with a diamond burr or a 15 number blade, and that's the donor ready for insertion. Coming to the recipient. So again you mark the central part of the cornea, and with help of your regular crescent, you can create a mid-lamellar pocket, and using the Summer-Busak dissector that we use for DSEC, you can extend this pocket into the marked area. And once you create this mid-stromal pocket, make sure that you hydrate it and wash out all the blood that is there in the interface, and nicely hydrate it for the stromal implant to go inside. So this is like a regular SICS tunnel. It would not require a suturing post-operatively. This is the lens glide. Just place the Bowman's layer transplant. And you center it well and iron out the folds with help of a regular spatula. So that's the end of the surgery. And that is how post-operatively the transplant would look like. So these are some of the very first early cases that we did. So if you can see here, the pachymetry improves and also the cylindrical value reduces. And all these cases, vision also improves with contact lens. This particular case has a very dense scarring superior limbal, a case of VKC in a 16-year-old. In these cases also with apical scarring also we could attempt and do this technique. So these are all the results. So we have been doing this technique from June 2017, and so far we did 24 cases. The primary outcome of stabilization is possible in all the cases. So these cases are done in cases that are not suitable for cross-linking. At the same time, you don't want to go in for a corneal transplant. So these cases we can avoid the transplant, and all these cases because of flattening and better shape, these patients become tolerant to regular contact lens or scleral contact lens, and they have an improved visual outcome. So the elevation maps also you can see they come down. These are the reduced higher order aberrations in the initial cases. We are doing the publication for all the 24 cases now. So combining with cross-linking, we try to do it in 3 cases. We always prefer to do it sequentially rather in a single sitting. We did it in 3 cases and very early experience of 6 to 8 months follow-up. This has also yielded good results. So take home is BLST is a novel technique that has a beneficial role in progressive and advanced keratoconus in candidates that are not suitable for cross-linking and too early for a graft. The primary outcome of stabilization can be achieved in all the cases. Secondary outcome of better contact lens tolerance and visual improvement also can be there. Improvement in pachymetry, unlike isolated Bowman's layer, makes it eligible for a cross-linking in future whenever required. Reduction in astigmatism and higher order aberrations gives them good quality vision. This procedure, when performed at an appropriate time, can reduce the need for a transplant. Thank you for your kind attention.
Thank you, Dr. Madhu. Our next speaker is Dr. Vinay. As he gets ready, Dr. Madhu can take few questions. Is it just a stabilization or you are getting some flattening also? You mentioned
Flattening is definitely there, sir.
Okay.
And previously, because of the bad cones, you can't fit the contact lenses and all in this. But once you have this 100 stroma in the central part, overall there is a good flattening and patients also improve with vision.
And you don't have any issues of interface haze or
No.
quality
Actually,
of
whatever 100 microns we are doing, sir, at the end of 6 months, it becomes compact. It's only hardly 60 microns that would be left.
But what is the depth at which you are going?
Mid-stroma, sir. Because all these corneas would be below 400.
You are using particular depth blades or?
Yeah, initially we used to do it with a guarded blade that we get for DSEC. Now we are doing with...
At what depth?
Usually it would be around 150 to 200. I would rather tell it is a mid-stromal thing where you have a better grip.
And once again, on the case selection, your ideal case would be the one with the low pachy for...
Low pachy, not suitable for cross-linking.
Cross-linking, but not as advanced as that for a DALC or something.
Yeah.
Okay. So JK sir, yeah. Any comments?
Stroma heals, sir. Anything you put in the stroma heals well.
You are telling there is no scar formation.
No scar.
No,
You can-
is no scar. As he rightly is telling, his mother is no scar. Manual doing is we did initially. It's very tiring for surgeon. It's especially in thin corneas. So right now we adapted for femto because we bought it femto. Initial results are not good, so we abandoned after doing 10 cases. We started some 20 years back, 2004, 2003, like that. Then we learned, looking at back, that's what called research. You search again. What is research means? You search again where you went wrong. So we abandoned, then we started researching. Then it's a good technique. There are a few points we learned. I will tell in my presentation.
Thank you, Dr. Sujit, for asking me to be here. So what he has asked me to speak on is CXL plus. Is it all plus or minus? So what is cross-linking? It's induction of links or cross-links between collagen fibers or within the same folded fiber. How can we achieve it? Various different techniques are there: chemical, ionizing radiation, or photochemically. What we clinically use is a photochemical one. We use UV light with a photosensitizer. The advantage is there is no health hazard due to chemicals, no DNA mutations or risk of DNA mutation, and the penetration depth is adjustable because the photosensitizer we use is riboflavin, which is vitamin. And riboflavin has an absorption spectra of 365 to 370 nanometer, which is moderate UV energy, moderate penetration depth, and practically no effect on DNA. So what does riboflavin do? Generates radicals by absorption of the UV rays and utilizing oxygen. So the other advantage of riboflavin is it offers protection. Okay, the UV rays or the UV energy gets absorbed in the superficial layers of the cornea, preventing it going to the dangerous levels on the endothelial surface. role is, as I said, it's a, oxidation of the extracellular matrix. So that is important. The availability of oxygen is very important, I believe, to attain the, the mechanical stiffness which we need with cross-linking. So cross-linking consists of UV light, which excites riboflavin, the riboflavin which favors or causes the absorption of the UV light and excitation of the oxygen, and the oxygen produces the oxidation of the extracellular matrix and then cross-linking. Based on the irradiation, the types can be either standard, which most of us or all of us follow, is a 3 milliwatt per centimeter square, or accelerated irradiance. Then based on the fluence, low fluence, which is less than 5.4 joules per centimeter square. What is the standard is 5.4 joules per centimeter square, or high fluence one, which is more than that. Can be epi off or epi on. Standard is the Dresden protocol, where you remove the epithelium, use riboflavin 0.1% in dextran for every 2 minutes for 30 minutes. Then you expose it to 3 milliwatt per centimeter square for 30 minutes. Then the various accelerated ones. What is my personal choice is the 9 milliwatt for 10 minutes. Because it has shown to have almost same effect as the standard one. So epithelium of riboflavin 0.1% in HPMC, there is a M missing there, is the preferred one, because dextran will produce, thinning or detergence of the deepithelialized cornea, so that is not really preferred. Accelerated cross-linking, 9 milliwatt for 10 minutes is what I use. So what is plus? Plus is actually cross-linking compared with other procedures. As you can see, there is a huge list of pluses, and then there are a lot of, things which are, without evidence, which is being used as pluses. One of the major thing is, interrefractive surgery, LASIK or PRK with CXL. There are a lot of people using it, but then is there a real evidence in the effectiveness of CXL in these borderline cases? I would say no, so I don't practice that at all. So what I use most is PTK, PRK with CXL, and then in very rare cases, intacts or intracorneal rings, and then, phakic lenses. So PTK is with CXL, what is called as a Cretan protocol. The machine we have is a Examer, Wavelight EX500. PTK parameters are 6.5, optic zone 8.3, ablation 50 microns done, and this is followed by an ACXL. This is a small study which we did, which we compared, the PTK with CXL with mechanical debridement with CXL. And then what we have found is in PTK group, there was an, early stabilization of vision compared to mechanical group. Practically no big difference between an improvement. But then what we have noticed is there is a slight increase in the lines of, vision, which is improved in PTK groups, and more importantly, the possibility of getting loss of lines or loss of vision after CXL is much less in the PTK group rather than the mechanical group. None of the other values were of real difference between the PTK and the mechanical debridement. So when we compare PTK with mechanical, rapid visual recovery, probably some gains compared to in lines compared to mechanical debridement, and less chance of loss of lines compared to mechanical debridement. So probably, we can say it might give a slight better outcome in terms of vision when we compare PTK with mechanical debridement along with CTR. Then the other procedure which we do is topo-graded PRK with CXL. How we do it? We do a PTK, then followed by topo-graded PRK. My criteria, what I generally follow is the residual stromal bed should at least be 350 microns. The maximum ablation I do is around 60 microns, and the topographic cylinder is what I used to correct, somewhere around 60 to 70 is the maximum. Whichever is less is what I use. And then mitomycin C, I use 0.02%, 1 second for probably every micron of ablation. This is followed by accelerated cross-linking in the same sitting. 96 eyes, mean follow-up 16 months. All of them or most of them had significant improvement in uncorrected and best corrected visual acuity. Cylinder, there was a significant decrease. Kmax and steep K showed a decrease, significant decrease again. So topo-graded PRK with cross-linking does give improved visual outcome with significant flattening, but what is very important here is ideal case selection. And in highly irregular corneas, you may not get a good topo picture to do a topo guided treatment. So the next is, intracorneal rings. What we have access to in India, I mean, I have is only intact, so that is what I do. Not a very common procedure which we do. We can either combine it together or stage procedure. I generally do intacts, then followed later, few months later with cross-linking. This is an example which has, which shows a slight or reasonable improvement post intacts. If you can see the difference map, the inferior flat, is flattening and the superior steepening. So, in nutshell, CXL plus has definite pluses, but in keratoconus management. Does it have a role in the, the dubious topos in refractive treatment? Still, I think the jury is out. Personally, I don't do it. And then, where do you use in this case, this one? In progressive keratoconus. For me, this is the rough algorithm I follow. If the best corrected visual acuity is 6.6 and there is documented progression, then I do a PTK with C3. If there is vision is 6.9 or worse, best corrected, and if the criteria for topography guided PRK is fulfilled, then I do a topography guided C3R, PRK with C3R. If it is not fulfilled, if the peripheral thickness is reasonable, good enough for an intact, then probably intact with C3R is preferred. With that, thank you. Thank you once again, Swiss, for this.
And thank you, Vinay. For your PTK with C3R, what is the cutoff PACI that you keep? No.
Cutoff PACI is minimum. The
350 is the RSB you told.
350 is the RSB for PRK. At the end of PRK, if there is at least 350 remaining, I go ahead.
With 60, at least, maximum 60 ablation.
With maximum 60. I don't go above 60.
Above 60.
Even if it is, 400 after ablation, right, I generally go above 60. Now the question is, why not above 60 when we are doing, PRK for 100, probably 90? There is no answer. Okay. Then the question comes, why did somebody say 50 microns in literature? Again, I try to find out a good reason for that. There is nothing explained.
And PTK
again, why does the literature say 400 microns is the minimum which should be left after that? There is nothing. The 350 I have. Yes. Yes, exactly.
That's a laboratory evidence.
Exactly. And 3-4 years back, there was a poster in ESCRS from Saylor himself, who he has shown that, up to 320, I don't exactly remember the value, but 320 or 330 microns cornea he has safely done, and it doesn't cause any endothelial damage. Because the epithelial configuration. Okay, so apex of the cone, you have thinner epithelium. Okay, usually 30, 35 or even less depending upon how steep it is. So here we are fixed at 50 microns ablation. Okay, so it shaves off some of the cone, top of the cone. So that is the reason why it's better than mechanical ablation. Partly, yes.
Any other questions from the audience? Thank you, Vinay.
Thank you.
So next I invite Dr. Mohammed Shahbaz. He will be speaking on the endothelial grafting. Thinner the better. Dr. Shahbaz is Medical Director at Trinity Eye Hospital, Coimbatore.
Good afternoon, everyone, and thanks, Sujit, for inviting me here. So we know endothelial keratoplasty is just changing the internal layer of the cornea and leaving all other structures as it is. And there are a lot of evaluation, if you see, from DLAC, DSEC, ultra thin DSEC, DMAC, and only Descending membrane removal. So this is figure you see, what Sujit has asked me, thinner is better. So we have gone from thick, thin and thinner. So both the things are there. Thinner is definitely better, recovery is fast, results are better, but the surgical skill you require more in that, and it's become more challenging for implanting the thinner buttons. So what are the indications? Like we'll just skip this. So descending membrane endothelial keratoplasty was started in 2003. And this is like manual dissection, which I'm so this is a case like it's a bit complicated case. Multiple things are there. You have BSK, you have endothelial decomposition, and cataract. So I'm just nowadays I don't use EDTA. Before starting, we was using now just manually scrap of the epithelium, and this Tooks blade works very well. I feel that is as good as a diamond bar of Sir. Because it's clean the epithelium like anything. If you see that after removal of this, it will be crystal clear. Like, and to this extent, you can just this is the Bowman's membrane. We can remove the Bowman's membrane also. And I usually mark the cornea, and as usual, two side pores. And this is one observation I have saying. If the endothelium is not healthy, it gets stained with this trypan blue. Before I was never knowing this. Because of the cataract, I have done this. And then I saw this endothelium become blue. So this we can do in other case also, but by and large, because endothelium we are removing, so even if collapse, even if it's distort, we don't worry because we have to remove this. But it's become blue. That was like my observation in this case. And then usually I make 4 millimeter, and the manual dissections, as I was telling, thicker. Usually we cannot judge how thick it is, and most of the time we'll end up having a thicker graft because we are more worried about going towards the endothelium. I do dissection like open sky dissection. We will have lamellar dissectors. I don't use nowadays. Initially I was using, but in that I was not feeling very comfortable, so I just use crescent. You just open it up and keep on dissecting, and you can remove. So now we can do this layer we can use for anterior limb transplantation also. So marking is not very important, but the graft is slightly thick, so it's open up very well. I'm doing a taco technique, and just I'm doing a PI because I leave air after. I don't remove air. Just you fold it and see that it's open up very well. Because it is slightly thicker, so it has rigidity is still maintained. As you become thin, the rigidity is gone. So you have to manually open it, and that becomes more difficult. And this is the results you can see. This is a pre-op photograph, and this is day 1. And this is after 1 week. There's some amount of haze is still there, but this is a very complicated case, so we expect that haze. Now dissect, if you see, as the advancement has come, you have a microkeratome, you can dissect the anterior layer with microkeratome, and the thickness you can, depending on the head, you can have even thinner graft. So you can go more thin and more smooth surface. If you are dissecting manually, it cannot be smooth, the different layer it comes. So this is like pre-cut tissue we got. And you just lift the tissue. I usually mark, because in dissect it's not necessary to mark, but if you mark, you are more confident that the graft is in correct position. And this is a thinner graft. You can see it's like more flimsy and more like. Just remove the epithelium. It's better to mark the side port point because sometimes it's very difficult to search where it is. So nowadays I usually mark. Initially case I was not marking. So when you are removing under fluid or air, the chamber start getting collapsed. When you are removing under visco or viscot, the chamber do not collapse. But there you have to wash it thoroughly. When you are doing cataract, in that time when you do AC wash, it comes up very well. Now this is a floating descending membrane. I do dissect the cornea up to the mark which I have done, so that the graft itself can cover that. So requirement of suture will not be there. And as I put full air, so I will always do an inferior PI. And it's very simple, like just take a cutter and go and make a small PI. So this I made as sheet glide, like plastic sheet. I have not gone for sheet glide original. Just make a plastic sheet and put the graft over that and just slide it. Because if you make taco of this graft, it do not open up very well. So I wanted to go like straight. Now it has come in the center. The air bubble should be very properly put, because if you put in the side, the graft will move towards one side. So you have to be very careful here. This is also slightly decent, but this thick graft, this much thick graft, you can just with a spatula, if you shoulder it, it will come to the center. This video I don't have. Then ultra thin dissect, even as I told you, the head depends on the head. You can make it thinner. And then the DMEC. The beauty of DMEC is that even after surgery, you cannot recognize that some corneal transplant has been done. So I usually go with larger trephines, just to score the descending membrane to some extent, and then cut it with the appropriate side. Usually 8 millimeter we use. And after doing this, I come towards this cataract. This was again cataract plus DMEC. So I have done cataract surgery. The visco is there. So it's very comfortable and easy to remove descending membrane in these cases. So both the side. You have to be very careful. You should not go too deep. If you go too deep, it will take up the stroma and then it will not come. So you have to just be superficial, like from back side. And once I have removed that stroma, I was trying to remove it with IA probe itself, but it doesn't come. So I just remove it in toto and then pilocarpine and then PI. More staining is always better, because if you have to maneuver 2-3 times, the stain goes. So better staining, leave the graft for some time so that it gets folded. And now here your luck. If it comes in one go, it is good. Otherwise you keep on. So I always have an additional cornea, spare cornea, whenever I am doing DMEC. And if this graft doesn't set very well, I do a dissect for that. So dissect is like your SICS. When you are not confident about phaco, you come back to SICS. The result of both are almost same after 1.5 to 2 months. But yes, if you see the initial result, like day one, if you see, it is like, it doesn't look like that any procedure has been done. And 1 week air bubble is gone and it is absolutely clear. So thinner graft have faster and better recovery comparison to thicker graft. Thinner grafts require more surgical skill, as placing of the graft in the center and correct orientation become very difficult. So end result of both the surgery I feel is same. After 2-3 months, if you see, it will be like even dissect button become very thin. So you don't feel like there is too much difference. Thank you.
Thank you, Dr. Shahbaz. Wonderful videos. We'll take the question after the next presentation. Next, I invite Dr. J.K. Reddy, sir, to speak on corneal inlay procedures. New hope for ectatic corneal diseases.
Good evening, and last day of the last talk of the last session is it's a little bit tiring for everyone of you. So as Dr. Madhu has nicely demonstrated, you have seen this is the inlay procedures where you put a lenticule and it's supposed to work. So 7 to 8 mm size, even we used 8.5, 2 to 300, even I used 400 microns thick lenticules, 150, 200 microns thick pocket, even sometimes I used 400, a lot of combinations we tried over a bit of slowly over the period of 15-20 years, and femto, manual dissection, all we tried. And this is the microkeratome based one. I feel the deeper cuts, microkeratome is better than femto. Femto gives a little bit bad irregularity. So in microkeratome, I cut the lenticule, and pocket, this particular one we did with the femto. around 200 microns thickness pocket. Then open the pocket, and it comes very nicely. Pocket is not a big issue. You use a lot of energy there, 1.4 nanojoules to 2 nanojoules instead of 250. Generally we use around 1.6 nanojoules, so the pocket will form. Generally we make a large pocket, whatever is possible, 9 millimeters, 8.99 millimeters pocket. Then we insert the lenticule. Lenticule will be edematous initially. It looks white and edematous because the graft, it will disappear over a period of time and is spread out nicely. So we tried with the cross-linking, without cross-linking, intrastromal cross-linking, over the cornea cross-linking, cross-linked lenticules, each one of different techniques we tried over a period of time. It looks very nice. The surgery post-operatively, all can be done with topical anesthesia, and it looks very nice. Post-operative looks nice. And these are some cases, results, 3-4. The topography also improves dramatically, and the cornea becomes progressively thinner. The lenticule thickness, initially it will be just like in DSEC. The lenticule thickness keep on reducing. It becomes from 460 to 277, something like that over a period of years. And topography also improves very nicely. As Madhu has rightly pointed out, uncorrected visual acuity improves from 660, 5/60 to 624 or 6, maybe sometimes 618, but that's not the end. They need a better vision now, people for mobility. So that's the challenge now. So DALK easily we can give around 6.9, 6.12. So we shifted to DALK, we abandoned this technique one. For example, this is a 18 years boy and 618 in the left eye. So we thought, okay, one eye is good, okay, we'll go for a insertion of the one. This is the post-operative results, and he has improved. And this is the one that is kept under 200 microns thickness. And over a period of time, the total thickness, Madhu has shown 450, 500, but most of our cases are more than 600, 700 microns. The cornea thick it becomes like a rock and then like a thick ball. So these are the post-operative results. Patients improves 1 or 2 lines over a period of time. And contact lens, of course, they improve dramatically, but our aim is without contact lens. So what we learned over a period of time with this intralenticular, what Dr. Nambata has shown, with a decellularized cornea. This is not decellularized, that is a decellularized cornea which they are using from the laboratory, lab-grown decellularized cornea. In our results, the final outcomes without contact lens are not very satisfactory, and best corrected visual acuity is not great, and quality of vision also they are not very. They say I improved very well. They never say that. They say it's okay, but they are not very satisfactory. So we abandoned some 10 years, 7 years, 8 years back. But looking back at the technique, what we learned is we are keeping a little bit deeper implant. The results are not good. If you keep around 200 microns instead of 300, 200, 150 microns superficially placed, the results are much better. Thinner lenticules, some of the results are better. Thicker lenticules, there are a lot of folds which are never getting ironed out. So the lenticule 200 microns or even 150, 160 micron lenticules are giving better results than 300, 400 microns lenticules. And the Doron should be dried. The wet you put in the artificial antechamber, put here and leave it for half an hour. So it becomes totally dry, and then you cut it. That is better than immediately doing. That's what we learned. And topography changes happens over a period of time, even 3 years, 4 years, 5 years, keep on changing. And the central cones, they do very well, and never mix with cross-linking. Don't do cross-linking. Just put a lenticle and leave it. You do cross-linking, that results are bad. And smaller the lenticules are better. 7 millimeters, 6.5, even the results are better than 8, 9 millimeters. When we did 8.5, results are very bad. When we did a smaller one, 7 lenticules, 7 only the smallest size is used, they are much better. We want to retry. Then comes the next condition, PMD, where you can see here very nice thin one, where this also can be done. We are doing topically. We just make an incision and make with a crescent blade, with a manually done crescent blade, a pocket. It comes. This is a very soft tissue. These ectatic tissues are very soft. You don't need to worry. You don't feel the resistance of normal cornea. And young patients, Young patient naturally collagen is not cross-linked. You just pass the crescent, it get dissected. It should be a little bold, it should be a little younger, not 40, 35 years old people can easily do it, not at the age of 67, 65 like me, 60 years. Then put a small lenticule there. You fashion a lenticule and put it, and this is a cure. This is a cure for PMD. Don't for PMD to become worse. Once you diagnose PMD, you try to do it. You do it, it will work. Don't worry about that. So you put a lenticule there because it's not involved in the visual axis. There won't be dramatic flattening of the cornea. There will be a little bit, but you are stopping the disease process there. And this is the one, for example, this is 200 micron, 250 micron thickness. Now we got 800 micron thickness, and these are the many cases. It's a routine treatment now in our hospital for PMD. And a little bit improvement. Topographically, they are good improvement, but cylinder-wise, it will be more or less same. And these are the some more results. And this is the one, the glasses, contact lenses. We put ICL, we put a IOL, and when there is a cataract toric IOLs. Even I used up to 16 diopters, custom designed intraocular lens. They dramatically they improve. You put axis, they give 6, 9, 16 diopters with 8. A little bit calculation is a little bit difficult. You don't get calculators. You have to do with your gray cells, but it works. Then coming back to advantages, topical anesthesia, no graft rejection, and you stop the disease, and you don't handle them when they are very advanced, and that's one. Then comes the new one, the KSOS. It's not a new, this is our own. Susan is popularized around the world. She is Susan Jacob, and these are the, instead of PMMA, ICRS, intracorneal intacs, we are putting a corneal tissue. Right now we are using the allogenic. Maybe in future we may use a lab-grown collagen also. Right now we don't have access for that. So it can be placed around 50 to 300 microns thickness. So we again make the pocket with femto laser, somewhere between 5 to 6 millimeter, 9, 8 millimeters pocket. Then we fashion the graft. We can fashion it ourselves depending upon the topography. You can fashion different shapes, different thickness, and different sizes. So that is the advantage when compared with intacs. Intacs are fixed sizes. Here you fashion them and you insert them. The inserting technique is still not standardized. Where you keep on using that, you learn better. Each surgeon will become. So it becomes. So inserted, right now I am using that inserter, and some people they dry it for half an hour. My fellow, my registrar, Dr. Vandana, she dries with half an hour. It becomes like a PMMA. Then just she pushes that. Half an hour she will dry that. It becomes like almost like a PMMA. Then inserts. It works very well, and the results are very good in most of the cases. So this is a 360 degrees cares in a central cone, and visual results are really good for a period of time. And these are topographic changes that's happening. And in this case, you can see up to 11 diopters flattening with the intacs. So these are the OCT images, and where we are going wrong. This problem is ectasia is defective collagen synthesis by keratocytes. We are just putting some collagen, but we need to answer that. We need to answer some of the mesenchymal cells in the stroma. We have to stimulate them or put extra mesenchymal cells or somewhere from the adipose tissue derived. That's where we have to look into the future. And there are some reports are saying instead of using decellularized, we have to use a recellularized and take from the adipose tissue and grow the mesenchymal cells, put in the collagen, and we have to use recellularized cells. That looks like the answer for the future. So there are two things which in ophthalmology, generally in medical practice in the life, either we act without thinking or we keep on thinking without acting. So these two things are making the world worse place to live. Thank you very much.
Thank you so much, sir. Any questions to sir? So in any of those cases with post inlay with pachymetry more than 700, 800, any of them you have tried laser refractive surgery for final corrections?
We did one case. Initially results are very good. The patient improved immediately to 612, 69 parts. But after 15 years, 10 years, he came back to us. It's almost became a desmotocele. So we are not attempting now. We are not attempting. So, but that case we didn't do even C3R. We just put a implant. Then he came after 5 years, 6 years after implant. He improved, his vision improved. Some refractive correction was there. We did it, and he improved. Then after 10 years, he came. That is the longest follow-up we had, almost 18 years. Then again, it became worse. So like that, there's small. It's not a large volume, but we tried all different things. Right now, we settled with that. No cross-linking, superficial placement, 150, 120 microns thickness tissue place, and put a smaller graft, not a big bone, not a 8-9 millimeter. Put a 7 millimeter graft. That's where we settle now. That we want to try in few selective cases.
And for Dr. Madhu, like you told about sequential this thing, cross-linking and inlay. What is the sequence that you follow? The cross-linking. You do the cross-linking.
At least after 3 months, sir. 3 months. First we do the Bowman's layer transplant, and followed by cross-linking after 3 months.
And
we just, pardon?
Not in the same sitting.
No, not in the same.
Actually, we don't need that. What we learned, we did it.
Yeah,
That's
I
what-
think
please
now
do
I
not
can
do
take.
it. Please do not do it, because we are killing the ketocytes. So ketocytes are very tricky cells. We are not able to understand. Now, Prajna, you talk with Prajna, you will talk about lot about the ketocytes. But what we learned, how we interpretation is different. So the same results I can interpret different way. For example, cross-linking, they have shown excellent results. 100 cases cross-linking there. The cornea became 35, 34. Patient is not able to read anything. But 15 diopters flattening, averaged it out, and they are showing this excellent results. But actually, when it comes to the patient,
True.
it's worse.
Very true, sir.
So how you interpret the results, how you present is completely different from what is the clinical. That's Vinay, you explain.
Real life situation.
Yeah, I think we did only for 3 now. From his suggestion, we'll stop doing it.
Yeah, no, sir, I have a question for you, sir, actually. PMD is known to progress
Yes.
both
Very slowly.
both in terms of thinning and circumferentially.
Yeah.
So, how do you think this
So
will,
once you
this
put
will
it,
fare
so
in the long
it's
term?
like it's a more it's not biology. It's both physics and chemistry. So I am automobile fan, so I explain to you. You have a tire. There is a small bulge in the tire. What happens? Over a period of time, it becomes more. It won't stop in the side. So if you put a patch and close it, it won't extend. Same thing in PMD. You stop it, you put there and support it, it won't. See, because there is no strength there to hold it, the surrounding tissue will become thin, and once you support that, the surrounding tissue will won't bulge.
Yeah. Yes.
In PMD, you are using cross-linking also.
No. See, cross-linking is my opinion, we started cross-linking long time back, we developed our program, is the last resort we should think in. Even with CARES, we are now slowly stopping cross-linking with CARES. Even I met a lot of surgeons in Gulf who has done 2,000, 5,000 intakes. They are telling absolutely not necessary for cross-linking. Once you support, it will take care. The nature will take care.
Yes. There is a definite, school of thought that rings kind of stabilizes the cone and doesn't progress. Now, the other thing is for in PMD for the lenticle which you have created, how do you, titrate the thickness?
So manual cutting, it doesn't matter. 2 microns, it's not in the pupil area. Posteriorly, we cut it somewhere. We cut 1/3 of it, so 2/3 is left behind.
Like you were saying that you will dry initially.
Yeah, what we did, I didn't do it. My registrar, they found out the way. They, before, when I am doing my LASIK, they won't go into the theater. Poor people, they spend, they make the lenticule, cut it, and they put it on the Teflon block and leave it. So after half an hour, I go there, just like a PMMA. You just insert. This.
Will that induce more wrinkling in the center?
No. No, center we are not using, we are, these drives are using for the rings and for the PMMA,
Okay.
PMD.
Any other questions to any of the speakers? Young lady Turks. We have even younger upcoming corneal surgeons sitting here. So if we don't have any other points to discuss, we'll end this session. I thank all the speakers for wonderful talks. Thank you very much.
No, no, no.